Everyone. I'm Kimaya, Communications Director at ThinkWell, and I'm delighted to welcome you all to this very first ThinkWell Counterpoint webinar. Counterpoint is our signature series of webinars that we will hold every quarter. We will bring together experts from different communities of practice to positively challenge conventional wisdom about what works and what doesn't within health systems. We believe that creating spaces for contrasting perspectives will truly allow us to think more boldly, share critical learning, and achieve unconventional solutions that actually do work. So welcome again to our very first Counterpoint webinar, where we invite you to never stop questioning the status quo. But before I hand over to my colleague Matt to introduce today's topics and speakers, here are a few housekeeping items. We have simultaneous French translation available. If you would prefer to listen in French, please click on the interpretation icon and select French from the drop-down menu. Please also click on mute original audio if you do not want to hear English simultaneously. Throughout the presentations, we will use the chat function to collect your questions and comments, so please send them our way. Our speakers will address them during a panel discussion, and we'll do our best to pick up on key themes. A heads up that we will be recording this webinar and plan to post a link to it online once we're done. Finally, we will keep everyone muted except for the speakers. Thank you again for being here today, and we hope to see you at our future webinars as well. And now over to Matt.
Hi, everybody, and welcome to this Counterpoint webinar. My name is Matt Boxall. I work for ThinkWell on the Strategic Purchasing for Primary Healthcare project, supported by the Bill and Melinda Gates Foundation. Today, we're delighted to bring together experts in health financing and in family planning to discuss how best governments in low and middle income countries can pay for family planning services. We'll focus today in particular on how these financing decisions can ensure that those most in need can access quality services. This is an area I've personally been involved with for quite a while, and I'm passionate about family planning. Empowering women to have children by choice, not by chance, can transform societies for the better. To achieve this, for sure, governments must invest in improving access to quality family planning services. But it's also clear that the way those investments are made, how that money is spent, is critical. These decisions can be complicated by political rhetoric around health insurance and UHC, especially when it turns out that some approaches to UHC might not be as universal as promised. How can health financing reforms help ensure that quality family planning services are available for poor girls and women? And where does health insurance fit into that picture? Getting it right is difficult, but there are some lessons to be shared, and so I'm delighted to have such a great panel to help us shed some light on the issues. Our presenters today will share some of the latest thinking and evidence on the topic, and then we'll move into a discussion where we hope to tease out opportunities and risks of different approaches. We'll suggest areas for advocacy, for technical support, and possibly for further research. We start today with Jo Kutzen, who leads WHO's health financing team in Geneva. Who better to set the scene by reminding us what UHC is and what it is not, introducing some key concepts around health insurance, and suggesting some ways to help think through whether insurance is the best way to invest in specific health services. Jacob Kazungu, Research Officer at the Health Economics Research Unit of Kemri Wellcome Trust, joins us from Nairobi, Kenya. Kazungu will share the findings of his recent paper on health insurance in sub-Saharan Africa, looking at the coverage of health insurance and the equity of that coverage. And next we go to Jakarta. Prastuti Sawando Ibubeki, Special Advisor to the Minister of Health in Indonesia, will share her take on the latest discussions about family planning in the context of JKN, Indonesia's enormous health insurance scheme. What has JACN achieved for family planning? What challenges remain? And why are there discussions today about removing family planning from the benefits package? Finally, Sophie Witter, Professor of International Health Financing and Health Systems at Queen Margaret University, will take a broader perspective and ask what we know about sexual and reproductive health services in these formal membership-based purchasing schemes, sharing some global thinking about gender and equity in this context. After Sophie, I'll hand over to my colleague, Nirmala Ravishankar. Nirmala will introduce three panelists: Brendan Hayes, Senior Health Specialist on Sexual and Reproductive Health with the GFF Secretariat at the World Bank. Elisha Dunn-Giorgio is Vice President of Policy and Advocacy at PAI. And Nomi Fuchs-Montgomery is Deputy Director, responsible for driving impact at scale on the family planning team at the Gates Foundation. Nomi, Elisha, and Brendan will reflect on what they've heard, and Nirmala will also pull in questions that you have posted in the chat box and direct them to our presenters and panelists. Finally, we'll ask Caitlin Mazzilli, Senior Program Officer on the Health Systems team at the Gates Foundation, to wrap up. So, without further ado, I'm going to hand over to Joe to get the ball rolling. Over to you, Joe.
Thanks, Matt, and it's really great to be here. I am going to, next please, to try to give a sort of a conceptual framing of the issues and being very clear up front that my talk is not about family planning. It's really about how I think you should be framing any issue when we talk about the integration into UHC, so-called, and the ways to think about that. What this is showing here is simply that UHC is a set of goals. And at the end of the day, when we talk about people getting the services they need of good quality and without fear of financial hardship, that means we're trying to make progress on these two objectives: unmet need for quality services and financial protection. Next, please. So when we think about that, certainly one of the concerns often raised about UHC and when it's framed as achieving UHC is that it can seem unreachable. But if we frame it this way, in terms of sort of talking about an improvement agenda, not an achievement agenda, then every country can make progress on some combination of these objectives. So that's really kind of the practical implication of that way of thinking about it. Next, please. So unlike the title of the webinar, I want to be really clear that UHC is not a scheme. Okay. There are countries that attach the label to a scheme, which is fine. I think the label you choose is what works politically in your country. But conceptually, UHC is about goals. It's about, like I said, what we want, which is these goals that you see under it that are embedded in the definition of UHC. And conversely, health system strengthening is really about instruments. And so this difference, in a sense, between what we want and what we do, or what systems do, is important to keep in mind when we think about actually what is a country thinking about implementing, because they're implementing aspects, I guess, that are on the right side, at least as I'm looking at the screen, about the instruments. Next, please. The other important consideration of practical implication of UHC is really this idea that, unlike, let's say, traditional public policy from the 19th century Germany on the origins of social health insurance, where the intent of the policy was really about the industrialization agenda, the military agenda, reducing unrest in the workplace, and so forth. Since World War II, the idea of UHC emerged with coverage as a right rather than just an employee benefit. And if we think about translating that into practice, it has very important implications for decisions about the choice of revenue sources and especially the basis for entitlement, which I'll come back to towards the end of this talk. So that's really important, is to think about what a right actually means in a practical sense. And second, and very importantly here, is this unit of analysis. And this is this kind of issues of thinking, as I say, sometimes thinking from scheme to system. So a scheme, whether it's an insurance scheme or a health program, can make its members better off or its beneficiaries better off, but it may have negative or positive spillover effects. And when we analyze things at the level of a system, we need to be concerned with those. And broadly, the idea of reducing unmet need and improving financial protection within a scheme is less critical than the impacts of a particular scheme on those objections at the level of a population, right? So this really requires thinking and acting beyond one scheme, but really thinking about the overall governance of the system. Next, please. So this takes us then to what is health financing, and the cube, which I haven't seen for a while, actually. It used to be quite popular in presentations. The coverage cube is really about, let's say in an ex-ante sense, is really about choices on benefit design. So who is covered for what services at what out-of-pocket costs. But just getting the package right and defined doesn't help actually deliver it. And on the financing side, we need to think about all of the functions and policies around financing. And it doesn't matter whether your country has something called health insurance or not called health insurance, your financing system has to raise revenue, it has to pool those revenues, it has to allocate those to providers, and services are provided, right? One of the critical issues, again, is on what basis people have to be entitled to those services. So next, please. And this is what I'm saying here. The traditional social health insurance, and of course, private voluntary health insurance, is contributory-based entitlement, which is that only for those making a contribution specifically or on behalf of specific individuals and so on. And the real concern is that some who need services won't have access if they haven't made that contribution. And the alternative, which many countries do as well, is non-contributory based entitlement, which may be based on residence. As I said, it may be just for, let's say, for pregnant women and children under 5. It may be about specific diseases, poverty status. And as I'll come to, non-contributory based entitlement is really, when we're thinking about integration of priority program services, that's what makes the most sense. Next, please. So typically, and this is really another issue, is we tend to think of, and certainly where we've done most of our work, at least in my team in WHO, is this kind of agenda in relation to communicable disease programs. And it's very clear in those cases that even though most of them, so HIV and TB, for example, have very broad benefits beyond the individual receiving a service, but the services are still delivered to individuals for the most part, okay? And the idea is you want to kind of make those freely available to all who need them, not just on consequences of equity, but critically because of these, the potential for spread, right? So this is really the rationale for funding from general revenues and so on. So you would have to decide, those of you who come after me or in the audience who know more about family planning, how well this fits, but just to frame that. Okay, next, please. So what I'm going to do here is to kind of frame a sort of decision tree about, should my country integrate whatever health program into health insurance, as it's being called. And if we go next, really to say, what does that mean in a practical sense? It really means, it's about integrating the services supported through priority programs into a health insurance benefit package that would be purchased by the National Health Insurance Agency from the same pool of funds as for other services, with the idea, of course, we'd want to avoid having parallel systems or having a completely separate purchasing arrangement just for one intervention or one set of interventions, for example, and ideally using the same information platform. So when this question of health insurance comes up, it's really important to unpack it. And that's what I'm going to do in the next few slides before I close. Next, please. And this is sort of a kind of a decision tree analysis. So the first question, as I said, most important for thinking about this is whether entitlement is universal. And if we start on the left side, where it says no just for insured, so if you actually have services only for the insured based on contribution, then it doesn't make sense to integrate the priority program services, because you wouldn't want to say, well, you can have your TB treated or HIV prevention only if you're insured, right? That's really problematic. Again, not just for the individual, but for the wider society. If, on the other hand, you have non-contributory entitlement for all who need it, then we can continue to the next question. And just to say that this is not saying that all of the services provided through the fund have to be on a non-contributory basis. It's specifically the services of the priority program. So let's assume the country's decided to go with non-contributory universal entitlement. What should be the funding source? And again, on the left is what I might characterize as a belief in magic, saying, well, government doesn't have the money and people can't pay for it, so we'll get it from insurance. But of course, the issue is insurance has to get, the insurance fund gets its money from somewhere, from general revenues and from contributory revenues and so forth. So just kind of absorbing additional benefits in the same pool is unlikely to work, right? So it may, but it really is difficult to scale up kind of what you want as universal benefits without additional budget revenues. If, on the other hand, we say, well, formerly we had a national program for this service, and we're going to take some of the revenues of that national program and put it in the fund to then purchase those services on behalf of all who need it, that's a possibility. But then in turn, it means we need to rethink and reformulate what the national program is responsible for, if that national program will get out of the business of pooling, purchasing, and delivering. So then we go to the next slide. And then if we have all of those conditions met, then we look at the capacity, actually, of the agency for strategic purchasing. And again, on the left, if it hasn't really been doing much of that, just reimbursing, then you have to be careful, because yes, it's possible to maybe pilot strategic purchasing with these services, but given that they're high priority and of a concern, it might be a dangerous way to start. On the other hand, if that agency has good or is developing promising experience in terms of managing data, reporting, holding providers accountable, both public and private providers accountable, then it might be possible, and we can think of a contract between the national program and the health insurance fund. And next, please. So if we meet all of those conditions, universal entitlement, we get the budget transfers, we link to accountability for results, then even in a case where for other services, there's only partial population coverage, you can universalize the priority program services. And that will maybe set off, and this is the opportunity, which we need to explore, to set off some positive corresponding reactions, because if you're integrating the services, you want to integrate the underlying data systems for all patient contacts, regardless of their insurance status. And that way you start to build a more unified national database. You build in the accountability and reporting requirements. You combine that with the data systems and reinforce the capacity. And so you can click again, because now we've gotten to the promised land of creating this virtual pro-UHC cycle that can actually be stimulated by the integration of the priority program services, so long as those conditions are met. And I think that's it. Thanks very much. Oh, sorry, no, I had my summary points. I'm sorry. Again, a reminder, UHC is not a scheme. Separate what we do from what we want. When we think of a rights-based approach, which is implied by UHC, then we need to think of it different than just an employee benefit. For the priority program services, this idea of non-contributory entitlement really should be seen as non-negotiable. It doesn't have to mean that government generates new funding sources. It could be that, again, the existing sources of funds that are currently flowing into the priority program now get channeled over to the insurance fund. Fifth is a question. We don't know. Will we get better purchasing and service delivery? That's kind of what you're betting on, and how you set it up and how you adapt over time will be important there. And then this last question of thinking through how this might become a catalyst for an overall more unified health system. Now I'll thank you.
Thank you, Joe. That was brilliant, and I can already see some fascinating questions and comments coming up in the chat box for you to look at, Joe, and
I will look now.
and we can take that into the discussion. Now let's go to Kenya and talk to Kazungu about health insurance in sub-Saharan Africa. Over to you, Kazungu.
Thanks, Matt. So I'm going to talk to you about a study that we conducted where we examined the level and inequalities in health insurance coverage across 36 sub-Saharan African countries. Next. So we all know that countries are now committing to moving towards universal health coverage, and sub-Saharan Africa is not left behind, and it's increasingly reforming its health systems to accelerate progress towards UHC. But moving towards UHC requires all countries to scale up, access to good quality healthcare services wherever they need them, but also protect them from, experiencing financial hardships. But what we've observed from most of the countries in sub-Saharan Africa is that they are turning to public contributory health insurance mechanisms as a mechanism to remove financial barriers to accessing healthcare services, as well as extending financial protection to the population. From this study, we observed that, over the last 10 years, almost 38% of the countries included have established some form of national health insurance. Next, please. So we set out this study specifically to examine the level of population coverage with health insurance in these 36 countries, but also look at, how the health insurance is distributed. So existing inequalities in the distribution of any health insurance, but also specifically on the national health insurances. Next, please. So we obtained the most recent data from the Demographic and Health Survey for those countries. And we basically computed weighted means of health insurance with any health insurance, as well as specific types of community-based, national or social and private health insurances. And then for the inequality component, we computed rich-poor ratios, slope index of inequality, concentration indices, as well as we plotted concentration curves. And all this was done in Stata. Next, please. So to the first part on the results, level of health insurance. Next, please. So we find that health insurance coverage in sub-Saharan Africa overall is very low. So to a tune of only 8 in 100 people in sub-Saharan Africa are covered by any health insurance. And there is so much disparity across countries. So ranging from as low as 0.87% in Burkina Faso to around 78.7% in Rwanda. And as you can see, only 4 countries out of all these 36 countries in sub-Saharan Africa have coverages above 20%. And this is any health insurance. And if we move to specific health insurances, next please, we find that those countries with higher coverages often are characterized by having a national health insurance than private health insurance or community-based health insurance. So for instance, the Ghana's NHIS, as well as Gabon's SINAMS, which were established around 2003 and 2007 respectively, are mostly funded from tax revenue to the national health insurance scheme rather than through contributory mechanisms. In other cases where we've had very old national health insurance funds, such as in Kenya, which was established around 1966, we've had quite low coverage because of the characteristics of the scheme or the fund. in that, it was designed mostly for the formal sector workers, and there have been huge challenges in extending coverage, especially to the informal sector population, and therefore quite low coverage as of now. Next, please. So there were also variation in terms of some selected socio-demographic factors. So health insurance was, higher among, people across all countries, literally, those who are in formal employment, those who are in urban areas, except in, countries such as Gabon, where urban, rural areas have higher coverages than urban areas, but also, exposure to media was a key thing, so which is also related to socioeconomic status. And this brings around some inequality. So in terms of socioeconomic status specifically, a country like Kenya has, the richest, having approximately 40% coverage compared to 2.2 in the poorest group, whereas these countries with, tax funding mechanism, such as Gabon, having the poor actually having higher coverage than the richest. And if you look at this, for other factors like gender, so men in this analysis had higher coverage, significantly higher coverage than women. And this is perhaps explained by the high informality in terms of employment, in terms of for women who often are in the informal sector, and these insurance schemes are not well designed for people in the informal sector. Next, please. So in terms of specifically, again, inequalities, there were variations again. So the health insurance coverage in sub-Saharan Africa is general pro-rich, so more of the rich are covered under health insurance in sub-Saharan Africa. But most importantly, I think here is if you compare between inequalities for among countries with both national or public health insurance, as well as private or employer-provided health insurance, those with national health, so inequalities are much less in the national health insurance or the public scheme compared to that in private health insurance. So approximately 59% of these countries had lesser inequalities in the NHI than private health insurance. Next, please. So in terms of bringing this all together, we observed that health insurance in sub-Saharan Africa, as in health insurance that is de facto voluntary for the majority of the population, is not the best way in achieving population coverage, especially ensuring everyone is covered. And a key observation was that 3 out of the 4 countries with coverage above 20% were characterized by having their health insurance system significantly tax funded as opposed to dependent on voluntary contribution. So we strongly think that in moving towards UHC, sub-Saharan African countries should reconsider voluntary contributory health insurance mechanism and perhaps reorient their health financing systems towards more non-contributory or tax-funded arrangements, as these will both, contribute to increasing coverages, but also reducing inequalities in existing insurance schemes. Next, please. Thank you.
Thank you so much, Kazungu. It's just a fascinating piece of research. I thoroughly recommend your paper. to anybody who's interested in following up some more. It's sobering, but it's just great to get that concrete evidence. Thank you so much for sharing. Let's move to Indonesia and talk to Ibu Becky now.
Yeah, thank you. Thank you very much. First of all, thank you so much for the opportunity. At this time, I will share with you what has social health insurance mean in family planning. Next slide, please. Yeah. Many of you already knows that JKN is a single payers in Indonesia called JKN, and now it's already covered 80% of the populations, but we understand that UHC does not only means like X coverage, but also have to be an effective and qualified services. The benefit package is quite comprehensive, and in the implementation, we are entering on the 8 years of implementation, and there is still many challenging access, equity, and then out of pocket is still a high portion. And in terms of the family planning, JKN covers full range of family planning services, and the covered at both primary healthcare providers, both at the PHC and also hospital. As you can see in the PHC, we paid by capitation, and primary healthcare by capitation, including all the consultations for family planning, and this in the sexual reproductive health services, and then also in the short-term methods. But if we pay, the JKN pays fee for service, so top up, for injectable implants and IUD. And hospitals for sterilization, they pay for tubectomy and vasectomy. On the next on the next figure on the same slide, we can see that the JKN has contracted to both public and private providers in general. In the primary care, there are public primary care, but in the hospital side, we mostly JKN contracts with the private hospitals. On the very right figures that share mandates between national planning, family planning boards, we call it PKKBN, and then also JKN. So how this they define the task job division. So the family planning coverage, this is like a mixed funding. So National Planning Board do purchase and distribute to the subnational all the contraception device. They purchase and they distribute, and in addition, they also do health education and also line coordination with the other ministers. In addition to that, JKN is paying, contracting the providers and paying the claims. So basically what we already applied is a mixed funding between government as well as pooled funding. Next slide, please. On this slide, we will show you the trend before and after the implementation of JKN. On the very left, as you can see, there is MCPR is declining. Yeah, we at the national level set up a target of achieving 62% of MCPR, but unfortunately, we never achieve that. We always reach up to below 60%. And even after the implementation of JKN, the MCPR getting decline up to 41%. So this is one of the signals why we need to evaluate whether including family planning into as part of the benefit package of social health insurance is the right vehicles, you know. So the decline of MCPR among insured JKN is more significant compared to the uninsured. Yeah. To the next figure on the right, it shows very interesting point among the poor insured household. At the bottom pie, on the red bottom pie below, it says that 65% still willing not to pay out of pocket for their family. Yeah. So they even they are covered with the JKN, but they don't use it, and they are still willing to pay for their contraception device, and mostly through the private providers. On the right one, it's just a detailed analysis how JKN seems to be working for the long-acting as opposed to the short-term method. Yeah, the detailed analysis is shows by poor and non-poor, and then we can see that there is a significant increase among the poor, and long-acting is also effective for the insured people, among the insured people, and also from the eastern part. And the next one, the next slide, yeah, this is my last slide. On the left, we can see that from the national health account data, we can see that there is a significant increase of the health expenditures in there, and with the range from 8% to 12% increase per annum. And this is from the National Health Account data. And we can see from the red bar, JKN quite significant increase. Yeah. Unfortunately, the blue bar is for JKN, but on the red bar is for out-of-pocket. Out-of-pocket comprise about 31% of the total health expenditures. So JKN facing sustainability issues. So because of the comprehensive benefit package, and then also low contribution. So there is some issues actually that they will exclude family planning from the social health insurance because they said that this is not effective, MCPR will not achieve, and out-of-pocket is still high. But we just recently, I think last December, we have a new minister, and the new minister has no background on health, but he is very strong in and believe on investing on prevention and promotion. And he said that he will emphasize all the limited resources to strengthening the primary care, and then focusing more on prevention, and that's why the family planning still be included, to be included in as part of the social health insurance. So I think that's all of my presentation. To conclude, we just want to say that yes, Indonesia adding family planning to the package, but we still have many challenges in the future, how to increase the MCPR, to reduce the out-of-pocket, and also coordination between national planning boards and JKN. Thank you.
Thank you so much, Ibu Becky. That was fascinating as ever, and Indonesia really has a great opportunity to help figure out some of these questions and share the learnings with the rest of the world. A quick housekeeping issue. I noticed a couple of people have accidentally posted comments in the chat to panelists only. Make sure you click on the panelists and attendees comments. There is a vibrant discussion happening in the chat box, so please feel free to join. A lot of that is about the topics that Sophie will touch on now, including gender and rights issues. So Sophie, let me pass over to you.
Great, thanks everybody. Yeah, so I think I'm going to be very much building on the previous speakers, and also just as for Joe, to caveat that I haven't been working very specifically on family planning recently, but I guess this builds more on general work on health financing, gender and equity. So next slide, please. So the points I'm going to be making, and I think they're consistent with the presentations. I don't know if they're consistent with the chat, because I've been trying to ignore the chat until after I finish the presentation. But firstly, as we've been seeing, that there are many challenges in terms of getting equitable coverage for national health insurance, and I'll be looking particularly at some of the gendered aspects. Secondly, that coverage doesn't mean utilisation, and there's a lot of barriers we need to be thinking about and addressing proactively. And thirdly, as we've seen from some of the presentations, there's also not an automatic relationship between utilisation and financial protection. And so what this brings up, I think, is the need to look at the wider landscape and also particularly think about things such as service organisation and distribution. So not just health financing aspects and entitlement. And that across the board, we need to be looking at these intersectional barriers. And there's a number of examples already come up, but around age, wealth, location, cultural barriers, intra-household dynamics, how all of these are factored into design, gender and equity generally. Next slide, please. So just to pick up some of the issues and maybe augment some of the presentation that we made around coverage questions. So we tend to look a lot at the socioeconomic dimensions, and from data sets, that's kind of an easier area to analyse. But the gendered aspects are very important as well, and particularly thinking about contribution-based schemes and the challenges that those present for the sort of life cycle of many women and their employment patterns, and of course also the reproductive health work that they undertake and how those can be barriers to coverage. So just to give some examples of figures that illustrate these points. So women are less likely to be formally employed. They're more likely to be employed in informal sectors. All of these are harder areas to cover with contribution-based schemes and employment-based schemes. Women who are more disadvantaged are also themselves less likely to be working full-time and within the formal sector. And the informal sector itself, even in schemes which have tax support, is hard to cover. And of course, women are doing more unpaid work. And a lot of the shifts that we're seeing in the global labour market may reinforce the challenges that this presents to these contribution-based schemes. I think it's also really important to think about insurance design. So where, for example, schemes cover a limited number of household members, we often find that women and girls are less likely to be included. And there are many other aspects around education, disability, refugee status, just as some examples, which can present challenges of equity for coverage. Next slide. So even if covered, are people going to use health insurance cards and access services? And we know that this is another sort of area in the cascade where challenges occur. So our colleagues have been talking about including family planning in the package, but as we know, in many schemes is not included. So that's already a challenge in terms of accessing family planning services. But even where it is, we have to look at the distribution of services. Are they accessible? Is there sufficient transport? Are they safe to access? Are they acceptable? Have we thought about issues of stigma and also practical issues around, for example, whether all household members and more junior members and young girls, for example, adolescent girls, do they have access to ID cards? Are they able to demonstrate entitlement and access services? And of course, we know these things, but they remain big challenges in many health systems, that the perception of quality is a key barrier. And as many studies show, it's often correlated with socioeconomic status, such that people of higher income will perceive higher quality of care or report higher quality of care. We also have to consider informal payments. As we've been showing in some of the examples, for many of the schemes, the systems for reimbursement, for example, are often late or inadequate, or there are blockages in supplies. And so people who have entitlements to health insurance often end up having to pay unofficially, and that clearly presents a challenge both for financial protection, but also for access to services. And then there is the issue of awareness. So, and just to cite one study here from India, in which family planning is included in health insurance, but awareness was estimated, use was estimated at 2%, and low awareness, particularly amongst poorer households, was found to be an underlying factor. And of course, on the supply side, we also need to consider the sort of degree of preconditions, particularly provider attitudes. Some providers are not comfortable with family planning services, particularly for some methods and also for some groups, such as adolescent girls and men. Next slide. So financial protection, as Joe said, is a key goal within UHC. And there is some relationship between being a member of a health insurance scheme, but it's not a very strong one. So a recent systematic analysis, for example, a systematic review, looked at this and found that in 26 out of 46 health insurance schemes, there were some, or studies of the health insurance schemes, there were improvements in financial protection for members. So there's a lot of diversity, a little bit as shown in the study from Africa earlier in the panel. So the underlying picture is that many of these systems do remain highly dependent on out-of-pocket payments, particularly low-income countries and fragile states, but also that the overall commitment to health is really not adequate to support the kind of UHC package which has been aspired to, and that's, I think, what Joe was calling magical thinking. So when there is a mismatch between the promise and the reality, there's always going to be a consequence for the user. And commonly, the national health insurance schemes are sold as bringing in additional funding. But more realistically, they can really only address the pooling aspects and sometimes, as Joe said, improving purchasing, but that's not an automatic consequence. Next slide, please. So obviously we need to be looking at the bigger picture. We need to be looking at how funding is, revenue is raised generally, but also around specific issues such as reliability of finance for commodities, which quite commonly are not funded on government budgets and are dependent on donors and are therefore more insecure and vulnerable. I think a lot of the people in the panel and I think in the chat are very engaged around this issue of provider payments, but clearly that's an important aspect. Looking at how to incentivize without coercion is a special challenge for family planning. But I think, as I said at the beginning, the service provision aspect is particularly important, not just issues of availability, quality and distribution, which I've referred to already, but also how, who is providing family planning services and how well trained they are, and the extent to which we are sort of meeting the users and the clients where they where they arrive. And so, for example, integration within things like postnatal care is very uncommon in many settings and is a kind of missed opportunity for client-centered service. Next slide. Just to highlight then on the equity side that this is also an area where we have quite poor sort of routine monitoring and tracking and debate around some of these trade-offs which are being made. And I've just given an example here from Ghana, as it's a country that I've worked in a lot, that we looked for a particular study at the annual sector review indicators. They were using 45, of which only 7 related to equity, and many of those were either not very informative or just simply weren't populated by data. So I think more generally we need to be looking at developing better routine monitoring systems to understand the equity trade-offs and access for different population groups. Next slide. And so more generally, thinking through the need to address these many barriers, which regardless of the sort of financing design are going to be key. So around information, gender barrier, cultural, religious, geographic, and others. And looking at a more sort of sensitive implementation and better joined up thinking between health and social protection programs to ensure that equitable aspirations are realised. And the final point, and this is very much consistent with what Jo was saying, is that essentially UHC is often understood simplistically as being insurance coverage, and the insurance coverage is the answer. It may be part of the answer, but in itself, without addressing these complementary elements, which reduce the barriers to equitable access, it can be relatively powerless. So I think that's my final slide. Thank you very much.
It is. Thank you, Sophie. That was fantastic. So much, such a rich presentation, and so much to draw on and to think about. Okay, it's time for me to hand over to Nirmala and ask her to introduce our panel discussion. Nirmala, over to you.
Thank you so much, Matt. And first of all, thank you, a big thank you to all the speakers who've just thrown out such a rich set of ideas and a lot of evidence. I also want to say in the live chat box, there's very lively discussion and a lot of additional links and content being posted there. And so after the session, Matt and I will work on collecting all of this information and sharing it with everyone through email, so you don't have to worry about having missed anything from the chat box. But now we get to, so we've spent a good part of an hour hearing from some of the leading health financing experts and health system strengthening experts, challenging the conflation of UHC with national health insurance, challenging us to think about how different population groups are included, excluded, and how some of these schemes can be made to work better for specific program areas and specifically family planning. And so now we're going to shift gears a little bit and hear from 3 distinguished discussants who've spent a better part of 2 decades, certainly a bulk of their careers, thinking deeply about family planning. And we'll be hearing from them whether some of these discussions resonate with the issues that they're seeing, that they've seen for the past couple of decades, and how going forward we should be thinking about ways to position family planning within financing arrangements in different countries. And so with that, I'm going to turn it over to our 3 distinguished discussants. First, let me invite Brendan, who works at the World Bank with the Global Financing Facility Secretariat. Brendan, I know you've been working on sexual and reproductive health issues for a long time and also been thinking about financing. So any reflections on what we've heard, and certainly if you have questions for the panelists, you're most welcome to pose those as well. Over to you, Brendan.
Great, thanks so much, Nirmala, and just tremendous presentations. And I think coming in, the presenters in our kind of pre-discussion, many of the presenters, Sophie and Joe, had indicated that their presentations weren't family planning presentations. And as somebody watching those presentations with kind of like family planning eyes on, or SRH eyes on, I certainly was seeing those presentations. And there's quite a lot that really resonated for me. A couple of points I'll just kind of circle back on, I think, that have been really relevant both to the presentations today and a lot of the discussions that we've been engaged in with the countries that we're supporting through the global financing facility. So one point that I think Joe made early on in his presentation is that UHC is not a scheme, it's a series of goals that we're trying to achieve. And I think as like countries are supporting a movement towards UHC, and as family planning stakeholders are engaging in this policy dialogue, I think it's really important that we're always keeping those goals front of mind, so that we are like constantly sort of sense checking the theory of change, if you will. The things that we're doing, are they actually going to help us achieve these UHC goals, which are very much grounded in rights-based principles that resonate for the kind of family planning community. And I'll just kind of point out one that really strikes me, particularly pertaining to this question of insurance. And it's really this issue of kind of revenue raising and the sorts of initial decisions that get made and how that can really shape that pathway in ways that are probably not always great for UHC and are certainly not going to be very responsive to the needs of women and girls for meeting their sexual and reproductive health needs. And I think we see in lots of countries the interest, and I should say that like social insurance and national insurance programs are getting talked about in countries, certainly. But I think most of those discussions are really trying to address a different problem than I think this kind of community of practice is trying to address. And the problem they're trying to address is very much a revenue problem. And we historically have seen a lot of focus on contributory schemes. They obviously tend to focus on civil servants and other formal sector employees. And I suspect that because of the populations that are being targeted for those contributions, and because those schemes need legitimacy, from the very beginning, they are shaped to meet the needs of a very specific, and in most countries, relatively small subsection of the population. And I think that really drives, obviously, decisions around what gets included in the package. And I think the family planning community is acutely aware of this challenge and has done a lot of work in this area. But equally, like as Kazungu pointed out, we have a covered populations challenge that goes hand in hand with that revenue raising decision. We have a levels of care problem. We have, are the types of outlets that women and girls are going to use for family planning access going to be included as service providers in those schemes? And so I think for many of us, we've kind of come into this at a little bit of a later stage, and not sort of always, and I'm speaking from personal experience, sort of reappraised some of those initial decisions that are being made, those initial policy decisions that are being made, and thinking through the kind of full implications. I mean, I came into this working for a service delivery organization, Marie Stopes International, and often like we were very focused on addressing a very kind of specific problem. Our kind of proximate problem was that we were working with private sector providers, we ran family planning clinics, and we were worried about the sustainability of those facilities and we recognized the importance of subsidized services for expanding access. So we were looking to address that who pays problem. And that sort of made sense, and insurance seemed like a good instrument for that. But I think like stepping back a few years out from that and thinking through, if a government has a limited pool of resources to allocate for expanding access to family planning, should we have sort of the full panoply of potential options on the table? Do they put that money into kind of community-based service provision through community health workers and contraceptive integrated outreach programs, or do they pursue this strategy of integrating with a national insurance program that maybe doesn't have a great deal of reach or is working with the right sort of service providers? So I think it's really a matter of kind of stepping back at this stage as we're engaging in this policy dialogue and really scrutinizing the goals we're trying to achieve and making sure that this kind of theory of change continues to hold up. I do think my last thing I'll say is, like on the positive side, I think that this has been a really important opportunity for family planning to think through how it integrates into national systems. I mean, Sophie touched on this, but for the most part, UHC is about expanding coverage of health interventions, but getting there for most countries also involves a process of really strengthening national health financing systems. And increasingly a big push is also moving towards greater integration with national systems. And family planning as a vertical intervention area is really poorly integrated in most countries in those national systems. And as Sophie indicated, really heavy reliance not only on donor financing for commodities, but also third-party procurement of those commodities. So there's a lot of issues on this road to UHC that we could be looking at that aren't related directly to insurance, aren't directly related to provider payment systems, but are really critical for advancing UHC and advancing family planning integration into UHC. So I think this is just a real kind of, a call to action for myself and for others to really be thinking more broadly about what UHC integration looks like, and thinking beyond just insurance and even the kind of provider payment systems, that there are a lot of elements of financial integration that we could also be tackling as we head down this road. Thanks very much.
Thanks, Brendan. And I couldn't agree with you more. It seems like we're all sort of coalescing around the idea that health insurance is not a silver bullet. It's not going to solve for everything. It certainly is not going to solve for the revenue problem, but even from the purchasing end of things, is it going to really reach all the women we're trying to reach? Is it going to reach, and from a coverage and a purchasing end? But in terms of where we go from there, and how we think about that broader system, and where we find the right kinds of levers to achieve what we're trying to achieve for family planning, that I think will require a lot more discussion between these two communities, which is also something I see others in the chat box making a pitch for. So let me, with that, turn to you, Elisha. I know you've worked for many years on advocacy for family planning services and family planning programs. How is this integration conversation, in your view, aiding or the way the integration conversation has been framed, with a focus on the inclusion of family planning within benefit packages for quote unquote UHC? What are some of the benefits of that versus some of the costs? And any other reflections on what we've heard from the speakers, as well as any questions you have, please, the floor is yours.
Thanks, Nirmala. What a rich list of presentations. I mean, my head is swimming a little bit from all of the information, even though I had the privilege of seeing some of the slides beforehand. I'm still really mulling over what the speakers said. I think to your question, and Brendan touched on this a little bit, I think it's been really important for the family planning and reproductive health communities to be able to advocate and integrate with national systems. I think that has been a great advantage in the national health insurance conversation and really broadening political will and acceptance around family planning and reproductive health in a number of countries where it's been hard to get a foothold on that. More broadly, though, I would say, I mean, the reflections on this discussion, I keep coming back to something that Joe said in his presentation, and it was in tandem with this conversation on what are the goals. And Joe said something like, raised a question around what does a right mean in a practical sense? And that is such an astute question for the complexity of this conversation. You know, the right to health, the right for women to bodily autonomy, the right for quality of life and quality care. You know, I think there are many answers to that. I think most of us, if not all of us, would agree that the right in a practical sense is not having insurance. You know, there is something so much more beyond the financing piece that makes a right actualize. And, you know, Sophie touched on this as well in her presentation, that if we think purely of universal health coverage as a financing mechanism, we're sort of missing the point, right? That is a tool. That's one way to achieve universal health coverage. And certainly in our work at PAI, where we've been working with civil society groups in several different countries to include family planning and reproductive health and insurance benefits packages, we don't see that as a panacea for the universal piece, right? That is one avenue to getting there. I think though we tend in the international development community to take a little bit of a reductionist lens to say, okay, so that's not getting to everyone. Let's take that away and put something else in that place. But people are complex, women are complex, communities are complex. And so we shouldn't be surprised or, I don't know, dismayed that we need a complex system to meet all of those needs of the communities and people. And so I don't mean complex in bureaucratic sense or, you know, difficult to navigate, but really thinking about universal health coverage and its complexity of responsiveness, of the multifaceted approaches that we need to take to it to get family planning, reproductive health, safe abortion care universally accessible is a very different thought mechanism than just saying, well, health insurance schemes, that's not where it's at, right? We need to do something different. I think this conversation, this type of reflection is actually what we need to be doing on a more frequent basis, because the other piece about health insurance or universal health coverage more broadly is that it's not static. You know, I mean, populations change, the needs of communities change. And so health access and health coverage needs to reflect that. And governments have to be responsive to that piece as well. And lastly, I'll just say, I mean, one of the things that I haven't heard very much in the presentations is the role of communities and the role of the end user of all these services in holding governments accountable, of helping to design programs that meet the needs of communities, of continuous social accountability and monitoring, not in opposition to governments, but in partnership with them. And I think that moving forward is one of the things that we really need to think about as the financial piece is designed or the structure is designed. That can't happen in the back room of a government building with a bunch of economists crunching numbers at the computer. We need actual community and civic participation in this for it to really be successful. It should be owned by the people who are using it. It should not be something thrust upon people who then have to figure out whether it works for them or not. Like, let's get ahead of that question at the beginning. I'll stop there, but I would love to hear from the panelists what you would like, what's the alternative? What would you like to see in the place of this, or what needs to happen to make it better? And I'll stop there.
That's a great question, Elisha, and certainly one that we need to make sure we save time to discuss where to from here. Let me move swiftly to Nomi. Nomi, come in and tell us how the Gates Foundation is thinking about these kinds of questions. Is this conversation mirroring some of the conversations you all have been having with different partners about the future direction for the family planning strategy? Over to you, Nomi.
Great, thank you. And I just, can you give me a thumbs up if my sound is working?
Yes,
great.
We can hear you and see you.
Wonderful. Okay, well, thank you for the question. And I want to join Brendan and Isha in thanking the presenters. Really, it's just there's such incredible information that was presented today and really dynamic issues raised in the chat. I've been thinking a lot about this in terms of as we, return back in different ways to potential office settings. And I really like the inclusivity that's happening in these virtual spaces and the dynamic conversations that can happen in parallel to the presentation. So just a big thanks to everybody for that kind of participation in the chat. I guess I want to start by saying, overall, it's been really clear through these presentations that we all need to work hard in ensuring contraceptive access and quality are really included in the measurement frameworks that are used to assess progress in both PHC and UHC. And of course, along the other relevant frameworks such as sexual reproductive health and rights and gender equality, which has been referred to. As Matt stated in the beginning, it's really critical that we recognize that there's not one size approach. Joe talked about this. It's from the presentations. We all recognize that countries are in different places with regard to PHC and moving towards UHC. Brendan reflected on this as well, that there's a desire there, but we need to be clear about the problem that we're trying to solve. And so with this in mind, I wanted to just offer a couple of suggestions of things that we've been thinking about and see if that resonates with both the speakers and the participants, many of whom I know have been working in this field for decades and have rich experience. So the first thought I'd like to offer is just that there is a real need to focus on locally appropriate analysis within country decision makers. I think this is a place where we're looking at the foundation in terms of how do we support that in order to make concrete progress on getting rights-based voluntary family planning included and paid for in essential health service packages. And so that locally appropriate kind of component and really supporting that in-country decision makers, including, as Alicia talked about, social accountability, those who are part of the community as part of that process is really critical. Second, collectively, I think we all need to push for better and more robust data to assess the family planning integration within PHC financing. And this came up in a couple of different presentations. We need to do this in order to better understand the viability of family planning integration. And this includes the quality and equity issues that have been raised. Martha talked about this in the chat. Others raised this, particularly given the number of barriers that women face. And Sophie, I really appreciate how you outlined this. These are not just financial barriers. And if we take a sort of narrow approach, we actually miss the full benefits. And this is critical given the necessary and frankly varying requirements of financing and operationalizing of these schemes. So this understanding this push for robust data to assess the integration, I think will help move us in the direction that we all want to go. And finally, I'd be remiss if not lifting up a little bit at a higher altitude in terms of our own collective effort, this moment in time that Brendan talked about in terms of maintaining the volume and increasing the quality and diversity of financing for family planning. And this, of course, is top of mind for us as we think about, and for everyone, given the recent FCDO cuts. So I do think this is a moment in time for us to be smart in how we link to country frameworks. We really think about that collection of data for those who are seen or unseen. And we had some conversation in the chat around adolescents, younger populations, those who are vulnerable. Sophie mentioned refugees. So really thinking about how we pull this together while also proactively supporting the pathways for domestic financing for family planning through the inclusion of PHC and UHC. And so those are kind of the big sort of anchor areas that we've been discussing recently, and I think resonate and build from the presentations. And if I can just maybe one moment to kind of drop down at a little bit of a lower altitude to say that from a family planning perspective, when we first began to partner with ThinkWell, it's been a really fantastic engagement over the last several years. There really wasn't much evidence on the dynamics between government UHC policies and programs for family planning impact. I know, Ben Bellas, I saw you on the chat. There are a lot of people, again, in this webinar today who've been working on this and really taking a collective effort to kind of hone in on that evidence. So the type of work that was shared today is such an important point in starting to shed a light on some of these nuances on how policies can drive access to scale while ensuring that services aren't coercive, there aren't these perverse incentives, that we take a feminist lens, as people have noted out. And without such evidence, I think we really run the risk of missing the mark. So I just want to thank all of the partners on the call who work really hard to gather that evidence, because without it, it's really impossible for us to think about a way to move forward. So I'll pause there. And again, thank you for providing space for us to be part of this session, and a huge thanks to the really dynamic presenters.
Indeed. Thank you so much, Nomi, and thank you all for this incredibly rich discussion. Now, of course, we have had some excellent presentations, some excellent responses from the discussants, and a huge sea of questions. And so I'm trying to think on my feet how to structure this conversation in the remaining 15 minutes. It seems like there's a group of questions around, how much should we be focused on national health insurance? And I think one of the earliest questions was to Jacob, to Kazungu, about, if the coverage of health insurance is not very high in a country, that's not to say there isn't coverage through the public system. So is it a problem that coverage of national health insurance is low? And indeed, that seems to be the point that Jacob, you were making in the paper, and Joe, I know this is really something that you're passionate about, pointing out the difference between an insurance and an insurance function that could be served even by a system that's not called insurance. So I wanted to pose a question to both of you, or rather give you a chance to come back on this sort of critical point that we're trying to drive home, that we need to think of the whole system and the different mechanisms through which we're trying to reach people, as opposed to just focusing on one health insurance scheme per se. Second, I see a lot of interesting questions around provider payment methods for family planning, whether they induce supply, whether they are coercive, whether they impinge upon a rights-based approach. And I know the GFF has been doing a lot of thinking around monitoring and evaluation of these kinds of incentives. And so, Brendan, I wondered if you could weigh in on that question and speak a little bit to that discussion around provider payment methods. And certainly, Joe, insights from you on that as well. And then there's a third part to this discussion around reaching high-risk population groups, particularly vulnerable segments like adolescents. And I've been monitoring the chat, and I see a lot of concerns about whether UHC can reach these groups. And so, Sophie, I wanted to give you a chance to come back on that question and speak to the concerns there. And sorry, on the provider payment question, I wanted to go back and also encourage Ibu Beki to speak to that in the Indonesian perspective. So let me turn this back, starting from the top, back to you, Joe, and put you on the spot. I know there's more questions than we can do justice to in the remaining time, but you're always phenomenal at finding a way to do that. So over to you.
Thanks. Well, just there was, I think you're asking about how to kind of embed these initiatives in a wider system, or is there some? Yeah, I mean, I think a lot of it comes down to be really clear, first and foremost, on what you're trying to achieve, right? And then, so you don't start with a scheme or so on, you start with your objective. And then you have to look at, okay, what does our system do? So I was thinking about this in the Indonesian case, and Ibu Beki can tell me if I don't have it right. But the idea that you have something that has, substantial population coverage, has developed capacity for purchasing, and that you've got individual services that may be preventive in nature, but they're still individual services. And the rationale for pulling that out doesn't make a lot of sense, right? Just because they're preventive, because from a from a functional perspective, what matters is not whether they're prevention or treatment, but whether they're individual or population based in terms of how they're organized, right? So that's one issue. And sorry, there was something else you said that made me think of some work we did a long time ago in Estonia, a long time ago. Yeah, my age is a long time ago. And let's say around 2000, a little bit after that, mid 2000s, where we were looking at HIV, TB, and health systems issues. And one of the points at that point was, should we be trying to integrate everything into primary healthcare? Well, it turned out that, while that sounds good, when you actually explored how certain underserved groups actually got services, so ethnic minorities, in this case, Russian minorities, who, they don't go to the primary care services. So you needed a different, in other words, you need a different delivery mechanism to reach them. And that's kind of what struck me in that other example. So, we need to just be careful of thinking we've got the solution for everyone, and especially when we think about service delivery, right? That needs to be highly differentiated depending on needs. Whereas financing, and we say this a lot of times in our course, which is that we want to make financing actually quite boring and leave all the innovation to service delivery. So in a sense, financing arrangements should provide the platform that enables people to really innovate in how they get services to people who can't get to services. So I think those are just some reflections that may have been related to the questions that you were asking. Thanks.
Thanks, Joe. No worries. I know this is, my head spinning too, just the rich discussion and the variety of questions. Let's go to Jacob next. Jacob, do you want to weigh in on the so what question when it comes to health insurance versus other mechanisms for financing services in the African countries that you've focused on?
Thanks, Nimala. First, I'd like to say that there's no one size fits all. Different settings have different contexts that, works best. So for instance, in some of the African countries, they're using, health insurance or having a health insurance card as a political mileage and not considering, the range of services or whether having the card guarantees access to care. So, I mean, that's a whole other debate that we can have, but really, I think, and the key recommendation as well that we're trying to make in this manuscript, the way we are trying to continue adopting contributory mechanism to, in terms of health insurance, won't work. And won't work, especially in these settings with high informality, higher poverty levels, and most people, again, work in the informal sector. So our context wouldn't allow such forms of, health insurance. And probably the not so magic bullet, but a better way into moving, ensuring that we're extending coverage to everyone is tax financing. Although, already taxing poor people might be an issue in itself, but by perhaps finding better ways into, subsidizing the poor people who can't be able to pay, whereas those informal sector continuing, doing contributory mechanism might move us there. But in the interest of time, perhaps my other colleagues can chip in on this. Over. Thank you.
Thanks, Jacob. Thank you. Ibubeki, any thoughts from you, especially on this question of payments? And there were lots of interest in understanding why FP services, women weren't accessing FP services through JKN.
Yeah, thank you. Thank you for the questions. I think related to the provider payment system, It's true that at the current payment systems, I think the systems do not give incentive to the providers, do not give enough incentive to the providers to participate, especially from the private midwives. As we know that the private midwives has a major roles in providing MNH as well as family planning. There are many issues regarding that, including pricing and including bureaucracy, administration. You know, when you need to submit the claims just for the low fare, you really have to work, you know, photocopy lots of stacks of copy, and that really make another burden for them. And then another thing is confusing because the national planning boards procure and distribute selected contraception device only to the public, but many of the clients, pregnant women or reproductive women, do not really go to the public primary care. They go mostly to the private midwives. So this kind of things need to be reforms, I think. So what we see from the data that we analyze at ThinkWell, so we are trying to identify what is the trend and how much is the out-of-pocket and where the JKN poor go and whether they spend out-of-pocket, you know, and what contraception method that the rich, the non-poor use. So that kind of detailed analysis are performs with our team in Indonesia. So we get a lot of information, and we feel like I think what we do is we're trying to prepare like a policy advocacy to the government and saying that maybe we need to integrate some of the, you know, funding, like what Joe just mentioned, to integrate the resources, the public sources, to the pool funding to JKN. So this is maybe when JKN was just started, it's okay to separate through different funding mechanism, but now I think after 8 years implementation of JKN, now this is the time for us to empower, give the strong authority to the JKN as a purchasers to the providers. So
thanks, Ibu. I'm so sorry to cut in, but we're going to run out of time. But I think that's a good note, I think, to end in terms of the discussion around Indonesia. Sophie, a minute to come in on, I know there's no way to do justice to the rich set of questions around gender and rights, but if you wanted to take a minute to reflect on how we bring these two communities together going forward, which I know you were also posing as a question to all of us in the beginning of this call, I want to give you a minute on that. And then Caitlin, I promise I won't forget about you.
Yeah, so I think your original question was more about vulnerable groups. And I think one of the things that's been hinted at, which is really important, is this idea of actually bringing in the users. So people understand the barriers they face. And I think the kind of use of deliberative fora in some settings has been a very good way of getting communities and service providers together to actually understand, and often very just small practical adjustments that can be made to address some of those wider barriers that we talked about. So I think that's a very important area. We've already talked about integration of purchasing and more equity monitoring and so on, but I want to just pick up on this issue of process quality, because it's come up in the chat as well, and I think it's really key that we are often not fixated, we look a lot at the structural quality, but the issue of the interpersonal and relational is really important to users here, and to bringing in some of those marginalized groups. And I think there's a lot more that can be done on working with staff on that, and also supporting them, because they're often at the sharp line themselves. So we victimize staff as well and blame them for bad attitudes. But there's a whole story behind that around autonomy and supervision and feedback and support that they get or don't get. So I think we need to be looking at that. And then finally, just, it's an obvious point, but we've got to be working across civil society on these issues, because a lot of them are around awareness, particularly the stigma and acceptance and so on. This is not something that the sort of public sector or even the formal sector can carry on its own. So I think a lot more that can be done in those areas. Thanks.
Fantastic, Sophie, and thanks. I think that question of quality, measurement of quality, and whether we link any payments to it and how, is certainly something we've been discussing internally. And I know Brendan and others at GFF have also been keenly interested in that. And maybe that's a good topic for the next session that we organize. With that, let me hand things over to you, Caitlin. I'm sorry, as you predicted, we are giving you very little time and an impossible task to sum up and thank people, but I know you can do it. So over to you.
No, thank you so much. I am overwhelmed by how robust this conversation was. And just as a funder of health systems work and as a development partner supporting governments, I just really thank you, because as Sophie said, what we might be prioritizing together is relatively powerless. And in the end of the day, we can't afford to waste time. And you're really pushing us not to do that. And I hope you'll keep brokering this conversation. I hope you will write this up. I absolutely hope you're reaching out to other service areas. And I was thinking through this conversation, and I know it's not new to many of you, but in maybe taking the lens of behavior change, if you will. And Elisha said this as well, but it's not easy to stop doing something. So I really encourage you to train us and teach us what should we be doing instead. That's probably more successful than just telling us to stop. So that will be I'm looking forward to learning more from all of you there, and hold us accountable to doing better work. And the other thing about behavior change is obviously repetition. Repetition is very important. I remember living in the UK, and a policy wonk was telling me that by the time members of parliament cannot hear a debate anymore, they're so sick of it, that's probably the tipping point where the general public has started to hear the message the first time. So unfortunately, you're going to have to keep going. You're going to have to keep educating us. And I really, really appreciate all the work that was presented here and the discussants. And thank you so much. Thanks to the team.
Thanks, everyone. Thank you, Caitlin. And if all the panelists could just turn their videos on one last time, it would be great to see you. And thank you, and discussants and everybody. And thank you all attendees for making time to join us for this first Counterpoint webinar. Bye. Have a good day.
Okay. Thank you. Bye-bye.